health service be able to actually be referred on to a health facility without having to go through the many ranks that somebody would go, like moving from level 1 to level 2 to level 3. That how can you be able to actually move from even a level 1 facility all the way to a level 6, where you find most of the comprehensive cancer centers being placed, so that then we can minimize the amount of time spent. We train, and we as a hospital, we've actually done a lot of training of frontline healthcare providers as to what to look out for in terms of symptoms of childhood cancer. And if there are certain basic tests we can put together to be able to clinch that diagnosis or even a suspicion, and then be able to refer them so that we can now have an opportunity to treat them with evidence-based protocols and maintain this data, because a lot of our challenges come in, even when stakeholders or partners want to come in, they ask, where is your data? And sometimes we don't have it because we haven't been keeping the records. Our registries are not very robust. So these are some of the things that we can do. So as we said, childhood cancer does not have any specific symptoms. In fact, this is one of the take-home messages that I really want you to go home with, that childhood cancer has no specific symptoms, because people will be like, what should I see? What should I look out for? And I'll share shortly that a lot of the times what you really do need is to have a high index of suspicion. And when you see symptoms that persist, symptoms that are not getting better, a constellation of symptoms, then this is the time to say, can I have a second look if the doctor in front of you is not able to clinch the diagnosis? I know we are talking about Breast Cancer Awareness Month, and this is October. And if you hear, most of the campaigns that we'll have is any woman or man should be really going out for screening from a certain age. But is cancer screening of value for childhood cancer? No. Most of childhood cancer is not amenable to screening. If you actually go out and gather a number of children and screen them for childhood cancer, you might not be able to pick even 2 or 3 cases. So the best strategy is actually to detect cancer early and be able to treat it. To detect it requires that you have the high index of suspicion that this patient who has come with very common illness symptoms might not just be suffering from either malaria or diarrhea or pneumonia, but this one might require a little more in terms of investigation. So this is one of our campaigns that we have been doing, and we reached out to a number of counties as a hospital, and we said that you are planning to actually be treating childhood cancer. So how are you able to detect childhood cancer? And a lot of these healthcare providers, being frontline, had never even seen or even interacted with a patient who has had childhood cancer. So we had meetings in Garissa, meetings in Mombasa, in Nakuru, and different places for us to be able to raise that awareness about these early warning signs of childhood cancer. Remember, most of them will be shared with other common illnesses. For example, malaria. We'll have children who come in and they have tuberculosis. Some of these symptoms are actually quite similar, but we say if a child is really pale, and that means looks whiter than usual, he's bruising early, he's having bleeding tendencies, this could be one of the symptoms of the leukemias. If there's any swelling, any lump anywhere on your body, on your child's body that persists for more than 2 weeks, and sometimes the doctors will see it and initially try an antibiotic or so, but it persists, that's a child you really want to be seen as early as possible for us to make sure that they don't have cancer. If a child is losing weight unnecessarily, we say most children are not in the gym trying to really lose a kilo or 2 here, but now you have this child, you're feeding them right, and all they have is they're losing weight. This is a child who probably could be having something going on. It could be a serious infection like tuberculosis, but also could be a sign of childhood cancer. A sign that is quite common for the cancer in the eye, we call it retinoblastoma, is that white eye reflex. You shine a torch on your baby's eye and you see that white reflex popping out. That is a very common symptom for retinoblastoma or the eye cancer. Any tummy swelling, and sometimes the little ones tend to have a big belly, but any swelling around that tummy could be a symptom of childhood cancer. And we say if you can put your hand there and feel if there's anything swollen, that might be helpful. But if not, take this child to a healthcare provider and they'll be able to see if there's anything going on with your child. Headaches. Children rarely complain of headaches, but if a headache is persistent and they keep telling you, especially early morning, they wake up, mommy, daddy, my head is hurting. Maybe once in a while they vomit. You might see other symptoms like a new squint, changes in their balance, their walking style. Again, this could be symptoms that something is going on in their head and they could be having a brain tumor. A swelling on the leg. Sometimes the children will come up with a story, I fell down as I was playing and now I have pain, but I also have this swelling. And sometimes if you really can't explain it, I think it's good that you have a healthcare provider have a look at it and be able maybe to take an X-ray or a scan and be able to tell you, could there be something happening? And most of our bone tumors actually come in with such symptoms. So again, we are big on raising awareness and we use every avenue. And this year we did have our third annual childhood cancer walk. And this is where we actually walk and raise awareness. This is a family walk and we urge you next year in March, when we reach out to you, please join us. Let us raise awareness about childhood cancer. It's a family walk. We like the children to participate so that they themselves are actually learning of these symptoms, because they can be the ones to say, mommy, daddy, I have something here. And I heard that this is a challenge and could be a symptom of some disease that might need a doctor's attention. So we have everybody else in the family, the parents, the brothers, the sisters, cousins. We have our childhood cancer survivors joining us and even flagging off the race for us to raise awareness about childhood cancer. Childhood cancer is a journey, and I always say, like that river, these are some of our childhood cancer caregivers, mostly parents, and we interact with them. And this photo was really, really telling because it's a journey. It's a journey that requires a balancing act. It's one that has so many dangers along the way. In that river, actually, there is or was rumored to have some crocodiles. And I know sometimes that is how they feel, that there are so many precarious issues going on in this child's life, in these diagnoses, as they go from one point to the other. But we always remind them that you're never alone, that we walk with you. And one day you will have to look back and see how far you have come and help even another childhood cancer family or childhood cancer survivor and their family to go through their treatment. So even in our hospital, we do have a number of childhood cancer cases. You can see world over, the commonest cancer is acute lymphoblastic leukemia. This is a blood cancer, and you can see it's actually even now hospital, the commonest cancer we see in children. We also have the lymphomas there, the brain tumors, the sarcomas, which are cancers of the muscles and the bone, the retinoblastoma, that's the cancer of the eye, the kidney tumors, which we call the Wilms tumors, and many, many other rarer tumors, for example, the liver tumors, and many other tumors that we treat. We were very happy that in 2019, a lot of our patients, whenever they needed to actually go through treatment, they had to have their treatment done in the inpatient. But now we have a daycare, and daycare is where they come in, they have their chemotherapy sessions given, and they actually go home. Why would you want to give chemotherapy in the daycare? It's because most of the time it's not only cheaper, but you're able to keep these children much more at home so that they don't have to be so disrupted. For example, don't have to leave their brothers and sisters for very, very long durations. So it actually even improves their outcome and improves how they go through their treatment, because then they come in, get their treatment, go home and enjoy the rest of their lives without having to have much disruption. Again, we say childhood cancer is never, never managed by one doctor. There's a whole team that actually manages our patients with cancer. We have the tall gentleman there is actually a surgeon. We have pathologists. They are the ones who actually make the diagnosis. So the surgeon goes in, takes the biopsy, and as they take the biopsy, then they give it to the pathologist. The pathologists look at it and they're able to tell us what they're seeing. And me as the oncologist, you can see me there as much young as I was. And you see that it's a whole teamwork. And sometimes we have to have even back and forth between these experts. Many, many other people there, the nurses, we have our radiologists who look at the x-rays and keep updating us how we are doing. We have our counselors. And these are all people who are very, very necessary in that team. So it's never a one-man show. It's actually a team effort. And we have had many, many difficult cases, sometimes even some that world over would actually be cases that most of would not survive even in some of the high income countries. And for example, this is a little girl who we saw at the age of 2 years, and this little girl had cancer in both of her kidneys. And I promise you, because if you only have 2 kidneys, so if you have cancer in one and you also have cancer in the other, and the treatment for this cancer is actually to take the whole kidney out. But because you have cancer in both of them, then it actually is not possible to do that. So this requires an excellent surgical team that is able to probably take a little bit of that cancer out, go get some treatment, get another bit of cancer out. And we are proud that now she's actually way past her 3rd year of survivorship with a little kidney on this side and a little kidney on that side. And you can see how healthy she is, that she has actually been cured of her cancer, and she's going on with her school and doing extremely well. And we celebrate our patients. We do. These little survivors go through so much to be able to actually come out and feel the joy of having gone through this journey, that we say that it's a journey that has so many dangers. But at the end of the day, they look back and they're like, we made it, and we celebrate them. And this was our victory bell once, and you can see the little princess there, the Superman boys there, Spider-Man, and they're feeling amazing. But what was touching is to actually see a parent who had a t-shirt putting down all the days that their child went through cancer treatment, all the seconds, all the minutes. It was very vivid in their minds. And to come to the end of it and actually celebrate their children, celebrate the progress they have made, it's so amazing. And for sure, to raise hope, we say we have had all these types of diagnoses, all these children with acute lymphoblastic leukemia, acute myeloid leukemia, Wilms tumors, sarcomas, the eye cancers, the germ cell tumors, those are cancers of the testes or ovaries, the lymphomas, actually who are in our survival lists. And the list is growing. That means these children, even in sub-Saharan Africa, in Kenya, can actually survive if given a timely diagnosis, early treatment started, and appropriate therapies followed up. These children can survive. We have a Gertrude's Children's Hospital Foundation, and we have several partners. Every year we do the Childhood Cancer Walk. We also do have a charitable golf tournament where we bring in different people who come in, and they do have lots of donations that we use to bring children from very remote parts of Kenya all the way. First, give them a diagnosis, and 2, be able to give them treatment to actually be able to change their outcomes. All these children actually came from very remote, some from Samburu, another from Chemolingot, and others from different parts of the remote parts of this country. And they got a diagnosis, and I'm proud to say that all these children are actually survivors of non-Hodgkin's lymphoma, another one a survivor of osteosarcoma, and this little one, a survivor of a kidney tumor. And we never leave our parents away. We bring them along. And the hospital actually does have a patient support group where we bring the caregivers, knowing that we may be treating them, but we might not know what their journey is all about. And this was really initially organized by one of our staff nurses who has been also through this journey. And she will bring in all these caregivers. And these caregivers get a cup of tea, they get mandazi, but they also get different times to share their story, get to interact, get to share even some of their challenges and some of the strategies they've used to be able to overcome. They're in different phases, different situations, and it's such a warm feeling when you see them putting together, supporting each other during different life events. And we take our caregivers, we share a lot of outdoor activities with them, and we want them to just come out of that hospital experience where they just have chemotherapy, radiation, surgeons, nurses, nutritionists, and we take them out and just have a laugh with them so that they are able to actually debrief and get to even know and interact with more caregivers, interact with their healthcare providers, and improve the overall experience as they go through treatment. If you ever see a child fighting cancer, it will always change your life forever. But what I can assure you is that childhood cancer is curable, childhood cancer is treatable, and we can do something about it. We need to raise awareness, but we need to also look for strategies to be able to provide care and improve the outcomes of our children. So I mentioned a little about sickle cell disease in Kenya. As you heard, this is also a very passionate topic for me because sickle cell disease is actually quite neglected. In 2008, the World Health Assembly actually recognized that sickle cell disease is one of the neglected diseases, and every year on June 19th, we come out and we raise awareness about sickle cell disease. In addition to that, we use September as also the month where we talk about sickle cell. And in Kenya, we are amongst the high burden countries that have sickle cell disease. We estimate about 10,000 to 14,000 new cases of sickle cell disease every year. Unfortunately, 90% of our children with sickle cell disease may not celebrate their 5th birthday. Why? Because we diagnose our children very late. We don't have any newborn screening. Newborn screening is the best strategy to bring them to care as early as possible. Small interventions that, like, for example, giving them antibiotic prophylaxis to prevent infections, making sure they have access to a disease-modifying drug called hydroxyurea that changes how their disease actually manifests. Transfusion, availability of safe blood practices, and that inadequate screening of chronic complications, which often cause them a very poor quality of life and even go on to limit their life all in totality. So sickle cell is actually one that with very little intervention, this is one I urge anyone who would care to listen, that there's so much we can be able to do for our children. With many interventions, we've seen that in our cohort of children following up in the clinic on sickle cell, comprehensive sickle cell care, most of them are on hydroxyurea on an appropriate dose, and you see it reduces their pain episodes, the number of times they end up getting admissions for transfusion, improves their quality of life, prevents them from getting most of the chronic complications of sickle cell disease, and now we are actively looking even for those chronic complications, so that we deal with them early, so that they don't end up causing them a lot of issues. Other than that, we as a hospital have committed to actually explore most of the newer drugs that would be able to help our patients with sickle cell. And that's why, as a site, we have participated in many international clinical trials, actually almost 20 as we speak. And 3 of the newer drugs that have been approved by the Food, Drug and Administration have been actually tried even amongst our patients at Gertrude's Children. So we are very proud to actually participate in clinical trials that is generating evidence to show that it works. So we want to tell you that we do provide, and we are even more enhancing the care of our patients with sickle cell disease, even going on to explore chances of cure. And we know, yes, sickle cell can be cured. It's inherited, but it can be cured. And this can be done through a bone marrow transplant. And with us as Gertrude's, we hope that this service of bone marrow transplant services can be availed to our patients, even locally here in Kenya. So yes, we can. We have a lot to do. We have many partners. We have many training programs that we can. There's so much that we can do for our patients to change their outcomes. And all we can say is, yes, we can. And we love to acknowledge our nurses, our team of exceptional multidisciplinary, our foundation and partners, the hospital administration that has always been pushing the agenda of children, quality care for all children, being a trusted pediatric center, and making sure we always have those children and their families at the center of everything that we do. Remembering they are fighting big battles, and all we have to do is to help them fight them and win. Thank you very much.
All right, thank you, Dr. Karimi, for being very passionate and that's very insightful discussion on childhood cancer and sickle cell. I think we'll jump right into the question and answer section and see whether we have any questions in our chat section and maybe get to explore and answer those. So please have your questions in the chat section. We'll look at it, we'll look at them and answer as they come. So we are seeing quite a bit of comments here, Doc. People are saying Evelyn Luvunga is talking about the conversation being very insightful. Someone else is saying, Davis is saying it's very informative. It's very eye-opening. And we are going to share the slides with you. We're also going to share the recording for the webinar. So let me look for a question. So Benson Wambugo is asking, are there any financing options for needy families in the treatment, Doc?
That's a fantastic question. And yes, we say we do support, and our foundation does support, and is still supporting many, but we still have a lot to do. I think look for so many financiers, talk to even health insurers that really there's all the benefit in treating. There might be chronic diseases, but yes, these are diseases that are curable, and we can actually do a lot in terms of facilitating their care. We do have many people, philanthropists, who are giving of their resources. And yes, if you do seek a number of foundations, you will actually be able to get a response as to how the needy cases can be assisted. So we have a diagnostic fund where we go through it and be able to get to one and a diagnosis, because remember, that's always a challenge. And then for some of them, we actually have them evaluated and put through treatment. And this money is really raised from well-wishers and our charitable events. We could do more, but we need more also into our kitty.
All right, so Felix Obuya is asking, are there child-friendly formulations of hydroxyurea? And if not, how do we prepare a child formulation from 500 mg hydroxyurea? So this looks like someone who actually maybe has a patient with them.
That's a fantastic question. And yes, we do. But it has meant that we have to be innovative. So we actually take the 500 milligram capsule and we compound it into a syrup formulation. And we then use that to give to the little children who are not able to swallow the capsule. We are hoping that one of the pharmaceuticals that does provide hydroxyurea that will bring a dispersible tablet. We hope that in the future that this will be an option available for our patients.
All right, thank you, Doc, for that response. Abigail Endea is asking, just wondering, how can one request for screening at birth, or what are the telltale signs that may prompt one to request for screening?
Okay, very interesting question. Again, remember we say childhood cancer is really not amenable to screening. What does that mean? That the best strategy for diagnosing for childhood cancer is not screening, it's actually early detection and diagnosis. Remember, childhood cancer is actually quite rare. We talk about it, yes, because we know it's something that we really should be picking out and treating, but childhood cancer is quite rare. So what it requires is for you as a parent to have that inner instinct that this symptom has gone on for too long. This symptom is not making sense to me, and go out and reach out to a healthcare provider who can be able to reach out and tell you, Mama, I think this one is it, or Daddy, this looks like childhood cancer. So that then now, if more tests are needed to confirm, then we take that. If not, then we declare your child doesn't have cancer. So remember, screening is not a very good strategy for childhood cancer. And there are a few children we still recommend can have screening. For example, those who are in families where there's been quite a bit of cancer in the family, cancer history. Remember, that's a question we always ask. Is there anyone else in the family who's had cancer? And sometimes we discover that there are families that one person has had cancer and those are the patients now. We follow up very cleanly to see if they will have any symptoms, and if they do, then we quickly go on to do some tests to confirm and then put them into treatment.
All right, thanks, Doc. Maybe as a follow-up to that question, I'd want to ask, from the statistics, you showed us that acute lymphoblastic leukemia is the most common cancer we've handled in Kenya. What would you say amongst the patients that you've seen, what would you say was one very common sign or symptom with these children that, even as we say that people should have a high index of suspicion, what would you say has something that you've seen being very peculiar or common amongst all these clients?
So for acute lymphoblastic leukemia, I would really talk of three symptoms. One is persistent fever. And a lot of these patients keep coming in and they have a fever, and then 2-3 days it's gone, it comes back again. And remember, fever is actually a very common symptom for many illnesses in children. So that combined with a child who comes in and has quite a bit of bleeding or has the anemia, when you look at their hands or their eyes or the tongue, you notice that they actually look pale. They look whiter, not pink, but pale. And then the other one is really when they come in and they're complaining, they have bone pains or joint pains, and this is persisting. And something interesting about this bone pain is that it tends to usually be much worse in the night. That means when they are resting, and you come in and you'll say, oh, Mom, my leg hurts. And this is something that persists. And especially if it persists more than 2 weeks, then that is something that you need to be wary of. Other things you may look at swellings, for example, swelling of the lymph nodes. They may have the swelling in the tummy where some of the organs are actually enlarged. Or they may actually come in and they have some nose bleeding or bleeding under the skin. But these are many, many other. Once you get to the doctor, they will be able to highlight.
All right. Thank you, Doc. We're seeing many more comments here about how educative the session was. And Valentine Jomo is saying, childhood cancer is real. Thank you so much, Doc, for the awareness. Daniel Kivaya is asking, diagnosis remains the most challenging part, not only on these, but other ailments. What would be your advice?
So you have rightly said it, Daniel, and this is the starting point, because I always say you will never be able to treat childhood cancer if you can't diagnose it. So diagnosis is very, very key, and that's why we reach out to teach even our frontline health workers. First, what are the symptoms that might lead you to suspect that the child has cancer? Then once you are a trained healthcare provider, once you put these symptoms together, then you're able to see what could be the likely cancer. And surprisingly, a lot of the initial tests that you require to do to confirm or to have a suspicion of cancer in children are actually quite available in our setting. In most of the hospitals we went in the counties, most of them are able actually to do at least a blood count or a hemogram. And this can be able to tell you whether this child has leukemia or not. We were able to actually see, they can do an X-ray, and an X-ray can be able to tell you whether this is a child who has a fracture or there's something swelling there and it's a cancer. If you have an ultrasound, and we have ultrasounds quite available, they are able to tell you in most of the abdominal organs whether there is something swelling there or one of the organs is having an issue, and this could be cancer. So a lot of the times the tests are there. I think it's putting things together. And one of the things that we have offered is that if you do have any question or if you're having any confusion, just reach out to us. Sometimes we don't want you to even come up with a diagnosis. It's just a suspicion. And we say it's a suspicion, send them to the right person. That person will be able to investigate, interpret the results, and if it's childhood cancer, put the child on the right treatment. If it's not, then we clear them back and we send them back to you. So early and timely referral is really, really the most important strategy that we can use.
All right. Thanks, Doc. There's another question here. Jacqueline Gary is saying or asking, my baby is 11 years now and has been complaining of painful legs. Sometimes she can't even walk. Could that be cancer? Could she be suffering from cancer or cancer-related issues?
So that's a grief fear. I understand your fear, Jacqueline. And sometimes when you hear all these about symptoms, you start feeling like, oh, I've noticed this about my child. But I always say, if your child is consistently complaining, remember, children never pretend. If they are not having those symptoms, then there's something happening in the background. I always say, try and put a pattern to it. And if you see maybe it's a certain time of the day, look for any other symptoms. But the best strategy, and this is my advice to you, is just have her checked out by a healthcare provider. Let them tell you this is something to worry about. If there is reason to do even 1 or 2 investigations, they will do that. And then you can rest easy once they say there's no signs that this is childhood cancer. Remember, childhood cancer is rare, but the symptoms you need are shared by many common illnesses. So you have to always remain on the high index of suspicion and be able to reach out to a healthcare provider. And this healthcare provider then goes on to be able to clarify whether this is cancer or not.
Okay. Thank you, Doc. Another question here, Sarah Bungay is asking, at what stage of cancer is able, I think it's at what stage of cancer is treatment, are we able to have treatment completely, especially in children? And another question, the follow-up is that, have you encountered a stage 4 kidney cancer survivor?
So I start with the latter question, that yes, we do have a number of stage 4 cancer survivors. I actually have one. And I'll tell you a little story about this child, because this is one, the person who diagnosed there's something going wrong was actually the grandmother. 2 parents who are running around working in Nairobi, and they go to visit their grandmother in the village, And she says, this tummy is too distended. And the parents are like, no, she's a little girl, she's growing, her tummy is just growing big. And she said, no, I don't think I'll have you guys stay until you get some investigation for this. So they, out of pressure, they just said, let us go and do an ultrasound in the local health facility. And shock on them, they never went back to enjoy their nyama choma at the grandmother's home, because they found that this child actually had a kidney tumor. And it was then go back to Nairobi, have a CT scan, and confirmed, yes, the tumor was there. And then the next thing was that they did a CT scan of the chest, and boom, there was actually cancer in the lungs. So this is actually stage 4. But she went through her treatment, and now I can bravely say that this child is actually 4 years post her treatment, and she's doing very well. Actually, we treated her when she was in class 7, what was their class 7, and now she's headed to form 3. So there is hope that childhood cancer, even at such an advanced case, still can be treated. But that's not where we want to diagnose our patients. We want to diagnose them much earlier, because then you end up giving less drugs. So yes, staging of most of these childhood cancers is done, and we do have them, and they can be treated, including even stage 4. And I always say, even when they're at stage 4 and we know this is not curable disease, there's always something you can do. You can take care of their pain. You can make sure that these patients have dignity. You can take care of the suffering that they have as a patient and also as a family. Thank you.
All right, Doc, Trufena, I think, is also still seeking a clarification. At what age should our children be screened for these kinds of cancers?
Interesting. I think, again, I still go on to say the message is cancer screening in children is not the best strategy unless there's a strong family history of cancer. And that is one that if you know somebody has had, you've had another child with cancer, and especially some of the cancers that actually are inherited. For example, the cancers in the eye, the retinoblastoma, we have an inherited form of it. Those are the children we really want to screen. If your child has one of those genetic syndromes, for example, Down syndrome, that is a cancer predisposing syndrome. Those are children, as doctors, yes, we want to see them often to just be able to see if they have any symptoms. Some will actually go out their whole life not having cancer, but those are children we have a higher index of suspicion. Remember, high index of suspicion for any symptoms that persist or don't make sense, please reach out to a healthcare provider for an early detection diagnosis, and then that is what will really save your child's life.
All right, thank you, Doc. Rotich is asking, my question is, what is the best way to overcome cancer challenges in children, or what is the support for children already affected by cancer?
So for children who already have cancer, remember, cancer is a life-changing disease. I always say, no matter what, yes, we can cure it, yes, we can treat it, but whenever you make that diagnosis, it's something that changes the whole family, not the child, but the whole family. And that's why we have to think of patient and family-centered care, making sure that we look around what are some of the dynamics going on, what are some of the issues. Even reintegrating them back to school is never easy, but we have to do it. And we help parents take their children back to school. And there's always that fear, will this cancer come back? So this is a journey you walk with these patients for a very long, long time, because relapse of diseases is quite real. And we have to always put it on the table and say, this cancer can come back, but we hope that we do a very good job and it's over. So I think it's really a journey. And I think we have to walk hand in hand together with ups and downs. But what we can say is we'll always do something for your child, and our goal is to give you the best of what we have.
All right, thank you, Doc. See, we have 5 minutes to go, but let me jump into the questions. What level of headache and nose bleeding could be a sign of childhood cancer? That is from Maurice.
Okay, Maurice, any headache that goes on more than 2 weeks, but anywhere between 2 to 4 weeks, consistently, early morning headaches, sometimes associated with vomiting. That is a headache we want to put on high alert, that this is a child who could be really having something going on in the brain and should be explored for a brain tumor.
All right. Thank you, Doc. Helen Matu is asking, which is the safest age to have a child with sickle cell have a bone marrow transplant?
All right, that's a very interesting question. Again, we have a window that we say this is the best time, and the age is between 2 years and 16 years. And people ask me why. And I always say, because that's the age most of their organs are still fairly okay. Remember, sickle cell is still a chronic disease, and the longer you live with it, it will have effects on your organs. So there's that window. But again, it doesn't limit, even if you have an older child or a young adult or an adult, still, if bone marrow transplant is needed, they still can be offered that treatment.
All right, thank you, Doc. Kelvin Kiplangat is asking, why is sickle cell more common in certain geographical areas than others?
Kevin, thank you. That's an interesting observation. And yes, sickle cell ideally was found in certain areas. And if you take the malaria map and you take the sickle cell map, you'll actually put it together and they almost oppose, because sickle cell trait, where that means you're the carrier of the disease, you don't have the disease itself, is a way to be able to actually help you adapt or survive in a malaria endemic zone. But sickle cell trait of sickle cell carriers don't have any symptoms. It's only until they marry another sickle cell trait and they have a child who gets sickle cell that they know that they actually have the gene within themselves. So sickle cell is actually found in areas where there's a lot of malaria, and it was meant to help people in that region be able to adapt to living with malaria.
All right, thank you, Doc, for that response. Joseph Gutiku is saying, comment and a question. So thank you for that quite informative presentation. Is there any existing policy on childhood cancer in the country? If no, what guides the implementation of childhood cancer programs in the country?
Very, very interesting. I don't think we have a childhood cancer policy yet, but we generally do have a national cancer policy. We also do have a national cancer strategy that usually is there for 5 years. And within the cancer strategy, we have childhood cancer as part of it. Now, we are also having a childhood cancer technical working group within the Ministry of Health. And this is again charged to coordinate the issues of childhood cancer in the country, looking at it from diagnosis to treatment to survivorship and follow-up, and to many, many other things like the supportive and the resources required to treat childhood cancer. So I think we're making steps in the right direction. And I think the future is bright, and we hope that we continue getting as much support as we can from the Ministry of Health.
All right, thank you, Doc, for that. There's another question here, but I think this is from the BRITAM side now. So Kohana is asking, does BRITAM have a child cover, and can someone visit the BRITAM offices? Yes, Kohana, yes, BRITAM, the retail health insurance products, Milele has a Milele just for kids. That is a cover that you can cover only your children. And for any inquiries, I'll request us to have our contact center number in the chat section, and also our email, where anyone who is interested to learn more about that can have this inquiry and protect their loved ones in this regard. So I can see a lot of emails shared here. I think for the recording of the presentation, then we will definitely share this. A lot of comments on how educative the presentation was, Doc, and how informative this webinar is. So thank you so much. I think it's been a great session. I'll do one, maybe two final questions before we give our closing remarks. So Mary is asking, is it common for a child to be diagnosed with ALL at 17 years?
So ALL, actually, the peak age for diagnosis is between the age of around 3 to around 7. But yes, ALL can actually be diagnosed all through your life. It's much, much more rarer in the second decade, like in that 17-year-old. It's not the commonest tumor, but yes, we do have children, adolescents and young adults who actually are diagnosed with acute lymphoblastic leukemia.
All right. Then there's Onesmus who is asking, I assume this is in regards to childhood cancer. So is cancer a lifestyle condition or genetically acquired? This regard.
Wonderful question. Again, remember for childhood cancer specifically, we are saying it really is not associated with lifestyle, and we don't have any modifiable risk factors. So that's the reason why childhood cancer cannot be prevented. Remember, when we talk about adult cancers, we talk about breast cancer, colon cancer, we talk about lung cancer, and we have some modifiable risk factors. For example, we'll talk about smoking, we'll talk about exposure to human papillomavirus. These are all preventable. And that's the difference between childhood cancer and adult cancer. So childhood cancers do not have many risk factors. And so it's really, really not a strategy we can use to be able to prevent. What we need is early detection, early diagnosis, and put them on the right treatment.
All right. Thanks, Doc. Second last question, I think it's also a comment here. We need more info on sickle cell since there's a lot more to learn. Thanks for the wonderful information. So I think it's been a great conversation. I think it's something that we can also take up to maybe organize a session on purely sickle cell, because clearly it looks like people want to learn quite a bit more on this topic. So thank you for the ones who've shared their emails here. We'll be sure to share the recording and the presentation. I think the meeting has also been streamed live on the Britam YouTube channel. So you could also go onto that platform and also watch that. So finally, there is a question by Kevin Goya on sickle cell, and let me just read it as it is. Hi, Doc, I have a sickle cell trait, but my wife does not have that trait, but she has a history of sickle cell disease in her family. Our 2-year-old boy has recently been diagnosed with alpha thalassemia. How can we manage this?
All right, that's a very interesting question, Kevin. And yes, if one parent actually has sickle cell gene and the other one has alpha or beta thalassemia, we tend to have beta thalassemia, then when they come together and the child has sickle cell on one side and beta thalassemia, they still will manifest their disease as sickle cell disease. So this is a child who really needs to come to clinic, and we need to start them on the treatment as sickle cell disease.
All right.
Yes.
Thank you so much, Doc. I think we've come to the end of this presentation. Thank you so much for being passionate about the topic, about the children and assisting our children. My key takeaway, I'd say, has been around parents, the need for us to maintain a high index of suspicion. Whenever something doesn't feel right as a parent, be more proactive in terms of just seeking additional support. And for us supporting the people who are going through this journey, the caregivers, the children themselves, the importance of social support, which is very integral. Doc, any parting shot from you?
So thank you very much for the opportunity. I appreciate, and really to just tell you that childhood cancer and sickle cell disease are here with us, and there's a lot we can do. We are doing so much for our patients. There's so much hope that nobody should feel so devastated that there's nothing that can be done. There is hope, and we can do so much for our patients. And karibu to Gertrude's, you'll find us all here.
All right, thank you. Thank you everyone for logging into the session. In case anyone is interested in the Milele Just for Kids cover, please reach out. I see my colleague has put our contact center number there. Please just reach out. As Doc had said, it's very important for us to be covered for our children and to ensure that we have the best outcomes. So thank you very much. We'll see you on the next one. Look out for this on our platforms. Thank you.